Hello, everybody. Happy Wednesday and welcome to this discussion, Covid-19 and Data, 1 year on, organised by the Data-Driven Innovation Initiative, or DDI for short. My name is David Lee and I'm merely here today to ask the questions while our experts share their views. We'll introduce them in a moment, but just to tell you, this is the first in a series of events about the impact of data on all aspects of our lives, organised by the DDI, which, if you're not familiar with it, is an innovation network which helps organisations tackle challenges in industry and society by doing data right to support Edinburgh in its ambition to become the data capital of Europe. The DDI is delivered by two universities, Edinburgh and Heriot-Watt, for the Edinburgh and South East Scotland City Region deal. And you can find out more at ddi.ac.uk. Before I introduce the panel, can I encourage you to pose any questions or post any comments in the Q&A box, please, not the chat box to the lower right of your screen. This is a big subject for an hour, so let's crack straight in. Our three panelists have all had a very significant part to play in the response to the pandemic and how data has been deployed to inform decision making. Professor Devi Sridhar is Chair of Global Public Health at the University of Edinburgh Medical School and has been a very regular commentator on our screens, airwaves and social media feeds throughout the pandemic. Professor Jason Leitch has been another very well-known face on our screens over the last year as National Clinical Director for Scotland. But I'll start today with our third panellist, who is Professor Nick Mills, who's the Senior Responsible Officer for the Usher Institute Health and Social Care Data-Driven Innovation Hub and Project Lead for DataLock. Nick Mills, for those who don't know, can you explain a little of what DataLock is and what it was asked to do a year ago in terms of creating the Covid-19 collaborative?
Sure, thanks, David. So I think we all will agree that access to data has played a remarkable role in guiding public health policy, our lives, and also the provision of healthcare over the last year. It's been a really remarkable year in that respect. And I'll give you two perspectives. One, as you say, is my role as clinical lead for the Data-Driven Innovation Programme in the health and social care sector for our region, but also a second perspective as a hospital doctor who works in the NHS throughout this pandemic as it unfolded. And I would say it was extraordinary in the first few weeks of the pandemic how insights were shared so quickly from colleagues in Wuhan, in northern Italy, in New York, through social media, webinars like this, and through rapid sort of scientific publications, some better than others. And the insights that we got in sort of real time were, on one hand, terrifying, but on the other hand, it kind of enabled us to prepare. And it was pretty remarkable how colleagues from across the health service pulled together, working in red and green zones in hospitals and learning from each other. DataLock is the core data repository and service that the DDI programme support. Now, that is directly funded from the UK and Scottish governments to help us work with the public, work with organisations in the public, private and third sector in order to support data-enhanced advances in health and social care. Now, we did not set up to provide support through the COVID pandemic, but just as we started, the pandemic broke. DataLock is a data service that is going to help us do lots more than respond to COVID, but we diverted our energy, our resource into providing insights real time into testing, hospitalisation, treatment outcomes for patients in our region. We worked very much in synergy with the health service. You mentioned the other higher education partners in the city region deal, but the health service is absolutely vital to this particular sector, and we work really closely with them and still do. We mapped data from dozens of sources, brought together clinicians, academics from lots of different specialties to help us collect and understand the data, and implemented, I think, something quite important, which was a streamlined governance process that was robust, which is now the governance process that we're going to take forward, beyond the pandemic. And within 8 weeks of the pandemic breaking, the data lock team were able to provide comprehensive real-time data, which we still provide to support multiple projects, lots of different areas in the region.
Okay, thanks very much, Nick. Jason Leitch, as you look back a year, what are your reflections on those kind of early actions that were taken and the way that data was used, the challenges you faced, and how that impacted on the response to the pandemic in the early stages and then as the months unfolded?
It sounds a bit glib, David. First of all, thank you for having me. It's nice to be stuck between one data expert and one global public health expert, so I pretty much don't have to know anything. So I can divert all the questions to the two other experts. It seems like the perfect panel for me, David, so I thank you for inviting me. This bit sounds glib, but the day after the day of reflection, which the UK had yesterday, it seems important to register the fact that 125,000 people have died. 10,000 people have died in Scotland with COVID-19 written on their death certificate, a disease we couldn't have written 14 months ago because we didn't know it. We didn't know what it was. The virus didn't have a name. So, therefore, you go back to Nick's story of that early discovery, let's call it that, in those first few months. And the global network of experts and leaders, including my two colleagues here and many, many others, helping us to get to a point where we would be able to respond. I think what people forget, though, and you maybe would expect this from the government guy, is the challenge of those decisions. What you place before the leader of a country, whether you run Estonia or Scotland, is a potential global pandemic that is going to kill citizens. But the cost you're asking them to pay is school closure, care home closure. We're going to say, right, we're going to shut mosques and churches. Is that okay with you? I mean, the scale of the decision making was like nothing I have ever seen or ever thought I would have to make. So your only hope in that space is to have as much evidence as you can have. And that is now much easier because of analysis that we now have that we didn't have then, and literacy that we have now that we didn't have then. I remember a relatively famous conversation I had with Chris Whitty when he said something, and I said, well, that's okay for you, but my leader reads the nerve tag minutes. Now, for those of you who don't know, nerve tag is the new and emerging respiratory virus threat group that most people didn't know existed. It's existed for years. So the First Minister of Scotland reads the nerve tag minutes. And Chris Whitty said, no, of course she doesn't read the nerve tag minutes. I said, no, she does. She understands the data. She's literate, partly because she was a health minister, and she makes choices based on those data. So therefore, when I go into the room with my colleagues, I better know it. I better have it at my fingertips, and I better be able to articulate what it means. And that's the data bit. So it's all very well having the table, but if you're going to interpret that at a country level, that's a huge, huge challenge, both for the advisors and then for the decision makers.
Okay, Devi Sridhar, Sir Patrick Vallance said yesterday, the one thing that I think would have been really important earlier on is to have much better data on what was happening, as he reflected on a year ago. Do you agree with him, and what specifically do you think would have helped to have had in place a year ago, and how would that have affected that immediate and longer term response?
Yeah, so I think, he's right in that we didn't have good enough testing capacity, especially in communities, to understand the scale of infection. And I think this is why some of the models, which are dependent on that data, were really off. So we thought we were 10 to 11 weeks behind Italy when we were probably 1.5 to 2 weeks. And so I think, going forward, a year ago, it would have been better to have much more line of sight on actually where the virus was, what were the levels and where it was. But to be fair to China and to the WHO, we had a lot of data by mid-February. When the China mission came back with Bruce Aylward, they did talk about who it affected clinically, what actually hospitals would need to prepare for what the fatality rate was. And so we had to combine that kind of existing knowledge from WHO with some trust. There was an idea we couldn't see the raw data from China, but some trust of the interpretation with actually having testing in place. But I think looking now, I think we should be positive of where we are. We're in a really good place data-wise in Scotland. We have sequencing that's steaming ahead, which lets us understand actually the cases in place. We have clinical trials being, coordinated in a way that I think other countries envy in terms of being able to assess, dexamethasone or remdesivir or others. We have really good outbreak management to understand where a cluster is coming from, and incident management teams to actually understand factory outbreaks or school or prison outbreaks. And we have research on vaccines because of the linked data set, so we can understand the impact of vaccines on hospitalizations or the impact of vaccines on transmission. And actually, in that way, I think Scotland's leading the world in this kind of research because of our linked data sets and because of that infrastructure that I know Nick has been very closely involved in building. I think looking into the future, though, the three things that come out for me in terms of where we need to be going is first around the surveillance of actually animals and the animal-human interface. Doctors are great at humans, vets are great at animals, and actually we're lucky in Edinburgh that we have kind of the College of Medicine and Vet Medicine. We have to be thinking about it as interconnected. And I think that surveillance needs to be in place, not just here for new avian influenzas, but actually worldwide, and how Scotland can play a role in that in terms of a viral surveillance network. The second thing is sequencing. We have sequencing here, but large parts of the world don't. And that's blind for us because we have no idea what strains are circulating and whether we're going to be hit by them. And the third is, I do wonder whether we need to revise in Western countries, our flu pandemic planning about kind of novel. The idea was always like 1918, the pandemic would just spread and we would all just be infected and we have to build enough hospitals. And in the process of trying to manage COVID, we've basically eliminated flu. I mean, Nick can say from the clinical side, but I mean, even child respiratory infections, RSV, hospitals are empty with the usual seasonal illnesses in the process of managing COVID, which is a more infectious virus. So actually, what does it mean for the future? At what level do we say we move into mitigation and we let a virus spread? And at what level can we say we control it? And if the fatality rate is high enough, maybe we don't need to say we actually move into mitigation. So I think maybe our flu pandemic plannings also need to become more specific based on data and also based on what we've learned over the past year about the measures that are put in place and how in the future, we obviously don't want to have lockdowns again, but at where do we move, when do we move from containment to suppression towards mitigation? I think that's going to be an interesting point of how you use data to move between those. So I'll stop there.
Okay, thanks very much, Devi. Nick, when it came to kind of bringing those data sets together, what are the main challenges of bringing data sets together from different organizations who collect and shape data in different ways? What were the biggest challenges you faced?
Yeah, I've worked with routinely collected data in Scotland for about a decade, so I'm pretty familiar with the challenges, mainly in heart disease, which is my clinical role. And the main ones are, although we've got really fabulous administrative data, which we've had for 20, 30 years in Scotland about hospitalisation, and we also have really forward-thinking policies with a network of safe havens that allow us to access this data when it's been de-identified, and charters that safeguard the use of that data, which are really important. It has remained a little siloed. So we have national administrative data under one data controller. We have regional and local data sets, which are just as important for that individual patient, who are held under different data controllers. And we've been quite good at getting insights in Scotland, but slowly. By going to each individual data controller to get permission to link and de-identify the data. And then suddenly you have a pandemic and you need information about care homes, about what's happening in primary care, how the hospitals are coping, and what's happening at a national level. And you suddenly need all these approvals straight away. So I think it is partly been the governance model and the pace of data delivery has been a challenge in the past. And for good reasons, to safeguard the secondary use of data. And they've had to be overcome. And it's easy to overcome them in a public health emergency because it's vital. But it's how we learn from that and have a more, I think, efficient, streamlined process going forward that allows us to use similar insights for, as Debbie said, for other, epidemics that we face on a regular basis and other public health crises, which Scotland still has with heart disease and cancer and many other conditions. How do we manage them more effectively, learning from what's happened over the last 12 months?
And Jason Leitch, was there a weakness in the sharing of kind of NHS and social care data in the early stages? There have been some criticisms in that area. Was that a weakness, do you think? Should we have been in a better place, particularly after sort of exercise Cygnus in 2016?
I don't think there was a weakness in the sharing. I think people shared what they had. I think that there is a weakness in both sides of both columns of available data. I think the troops, for lack of a better description, want to be able to do that together. Now, we have a much more mixed social care thing than we do a health service thing. The Field Review talks about that quite extensively. I would commend it to people if they haven't looked at it, about what the next stage for social care reform might look like following the election, depending on who wins. Data has to be part of that. The nature of social care and its evolution has meant that they are not necessarily in the same databases as the rest of us, and Nick's team and others don't have access to that data linkage that Devi talked about, where we can compare X with Y and think about outcomes rather than inputs into that process. So I think there is valid criticism of our overall data landscape, but I don't think it's as easy as saying it's a sharing problem. I think it's a constituent problem. It's what we have available to us that we need to fix. Then we need to do the sharing thing, and then we need to do the analysis. My extra challenge, and this is easy for a panelist to do, you can always trump the question with another layer. I would add criminal justice and education data into that same process, because you cannot answer the public health questions of our age if you don't think about truancy, you don't think about prisons, you don't think about social care. You have to add those other layers in order to do that. Some local authorities already do that. Falkirk and Stirling have an excellent process for bringing in police, bringing in teachers, where they have whiteboards of data that talk about A&E attendance, truancy, police involvement, all in the one conversation about a kid. That's got to be where that data at a very granular level gets to be used, and then we take it up to the level where we can start to give policy advice about what you should do as a nation.
Devi, have you got any observations on that, on how the health service and local authorities are often using different identifiers for individuals, or using property reference numbers, using community health index numbers and so on? Was that a challenge in the way that different organisations did data in terms of that speedy response?
I don't really know, actually, because I don't know enough about the data here. So I better just say I don't know. I can talk about something else, which is data in a cross-country way, which is that I think in places like Taiwan and Singapore and Hong Kong, they had much more access to private information of individuals and could use this for tracing and for other things. Whereas I think because of some of the data protection that we have also brought in through the EU, it becomes very hard to have what some might see as invasive surveillance of people's details in their lives. And so for me, one of the things that has come out is, looking at South Korea, they never really went into a harsh lockdown like we did, but people traded their privacy and their personal information for the right to movement. So credit card details are taken. So they can trace within 10 minutes where someone's been in a week. They know where you've been. They know who you're interacting with. I mean, look at China. Within hours, they knew that, Dr. Li, who was one of the first to mention this publicly, had sent a WeChat message about this. So I think for me, sorry, I'm going in a different direction. But what I'm trying to say is I think one of the things this is revealed is in the pandemic, how much actually can you get into people's data and into their information for the public good? How much are we willing to do that? Think of apps. Our apps are voluntary. If we want to make them mandatory, it's another step. And how much do we actually want to have our freedom of privacy, but it means we all get locked in our homes because there's no good way actually to pull out who's infectious and who's not. I just answered what I wanted to answer.
But so it's a good subject to go down. But the South Korean nightclub outbreak, everybody gave false information. So they didn't use the data in the way the government designed the data to be used. So we've had exactly those debates. We had them around the Protect Scotland app about whether we should enforce it, whether we should use it as a passport to do extra things. I actually don't know what I feel about that. It's got massive implications, but it has to be a policy and a political decision based on what the public want it to be. But it's got huge implications. Vaccines is the big one just now. Qantas announcing you can't travel without vaccine evidence. So what do we do with people who either can't or won't get vaccinated? And that has data implications, of course, about what evidence and what the evidence means. But then it has massive societal and human rights implications for what you're then allowed to. Am I allowed to go to nightclubs with, or I'm 52, it seems unlikely. The cinema, let's go there, with or without the data about my medical history. So my medical history is different from Devi's and gives me extra privileges. That feels like an odd place to go.
Do you think, Jason, that the appetite for people to share their data for good public health reasons has changed in the last year, for good or for bad?
So yeah, I'm not sure if it's changed. Nick might be better placed to judge the mood of the population. I think the population already think we do that. I think the population think that Stirling and Falkirk's example that I've just given is not unique. They think, why on earth would the hospital not know my drug history? That's just a stupid thing. So they believe that health and social care data is all linked already, and they may well believe that also links with other big databases. If that data is used for good, I have seen very, very few people complain about that use. If that's about child protection, or that's about good educational outcomes or good health and social care outcomes, nobody complains. There is, of course, a crucial layer of information governance about who controls that data, about who has access to that data. But we shouldn't let that manage the outcome, which is better public services and better outcomes for kids and adults across the country. I think people are entirely comfortable. I mean, 2 million people have downloaded the Protect Scotland app. We didn't think we'd get anything like those numbers across our population. My understanding is in countries that are much more digitized than us, like Singapore, they got nothing like that proportion of their population to download their contact tracing app. So I think the public, when you describe the why first, not the how first, will come with you.
Nick, any observations on that?
Yeah, I completely agree. We've been working with patient and public panels for a long time with routine data, and I've never really come across any resistance, and mainly people being baffled why we're not doing this already on a routine basis. And I certainly think that the public have got very used to getting data updates from Jason on a daily basis, and are probably a little bit overwhelmed by data at the moment, but I don't think that it's going to change. I think what Devi highlights, which is slightly more contentious, using personal private data, getting into your personal space, that requires a much wider discussion with the public. I think if it was ever to become a policy decision, where it's a personal decision whether you share data, it's very reasonable. I think most people are in favor if they can see, as you say, the value for doing it. But certainly our services, whether it's primary care, secondary care, or social care, it absolutely makes sense that we are communicating effectively through sharing data. And I think there will be very little resistance after the experience of the last year to do that.
Devi, do you agree?
Yeah, no, I think so. I mean, I think also what you hear is that many of the things that us academics on the outside think are not being discussed or being intensively discussed within government. And I think, Jason has said that. I mean, a year on, it's really easy for outsiders to throw stones and to say, why didn't you do this? And why didn't you do that? And of course, there needs to be a looking back. So we can look forward to say, if we had to redo the past year, what would we have done differently? So when we have the situation, which is a when, not an if, we're in a better position. But I think the thing for me always about the pandemic is there was never a good way forward. There's never an optimal way. It's all about trade-offs and how we explain those trade-offs to the public and how we bring people along with that, which comes back to the issue of kind of leadership and carrying people along and the balance of those. So
Yeah, okay. I just read your article that you wrote with Gregor Smith for CNN. I think you posted today, and you talked there about the very difficult trade-offs that are necessary. So I'd just like to move in, if I can, to that marrying of health data with other data, including the economic data and behavioural data. How do you think we've done at that, Devi, just that enormous wave of information? How have we done in terms of marrying that health data with the economic data and making those tough decisions, making those trade-offs as you describe them?
Yeah, I think one of the interesting things, and this is in the past week, having spoken to business leaders who are concerned the economic costs aren't being calculated adequately, as well as to education specialists who feel the harms to children are not being calculated accurately, is that what we could never do with this pandemic, and I think everyone would agree, it took a long way to get there, is that we couldn't have said COVID cost this many lives, the cost of the economy restrictions is this much, and the educational harms are this much, and then we're going to choose. We're going to choose COVID, or we're going to choose education or the economy. And that was kind of one of the things people set up. Where I think what we've learned is actually, if we don't manage the COVID harm, the harm to education and the economy is inevitable. You can't save the economy or education by not dealing with COVID. It all kind of tumbles together. And I think the two issues, because I know there's many people concerned about lockdown, and nobody wants to be in lockdown. Nobody wants to have economic harms. The data is clear. I mean, we can see it coming from economists, as well as the education data on what's happening with children, is that the two things that keep getting us with this virus is how many people are susceptible, which means you constantly have exponential growth because it jumps and it spreads too quickly. So you can't really simmer it because it moves too fast. And the second thing is that the hospitalization rate is so high that your hospitals become full very quickly. So you put together the exponential growth and the hospitalization, and then your health system gets to the brink of collapse. And then you see what's happening in Brazil when you actually have an uncontrolled epidemic, which in my view is like medical hell, which is like you don't have oxygen, you have so many patients, you have hundreds of people waiting for ICU beds. So in a way, we can talk about the economic harms and calculate them. We can talk about the educational harms and try to address them. But actually, it doesn't get us around that we need to suppress COVID. And we have to figure out a way to do it, which minimizes the economic harms and minimizes the other harms. But it's not like we could have ever made a choice. And I think that's one of the things that I'm not hearing enough in the public debate. There's this view that if we just lift all restrictions and we say 1,000 people die a day, that's acceptable. We need to decide on the right number of people to die, agree as a society and get on with life. COVID doesn't play that way. It's not going to say, okay, I agree to your agreement. I'm going to kill 1,000 people a day. No, it's going to keep spreading. And now we have variants. And so I think that's kind of the way where we have to deal with the data, but the data not to say we shouldn't suppress COVID, the data to say, how do we address those harms? And actually look forward to saying, how do we get kids back into school and support those who fell behind? How do we support those businesses that are close to closure? How do we get the economy going and get people back into jobs and employment? So it's more about managing the situation rather than balancing it, if that makes sense.
Yeah, sure, absolutely. And Jason, obviously there are limitations of data alongside, the need for policy making in all areas and also alongside politics as well. How well do you think data has been used right at the heart of decision making from your own perspective with all those other considerations at play?
I think it's been exceptional. Genuinely, I think it's been exceptional. The literacy of the cabinet in terms of their ability to absorb that broad data that Devi's just described has been very, very, very obvious, as it has been in the majority of the parliament as well. So I spend quite a lot of time with opposition leaders and opposition health spokespeople, and they also are very data literate. As are all the stakeholder groups, which you don't see us speaking to. We don't do them live on TV. So yesterday, I was with places of worship. I was with faith leaders. I was with the BEMIS organization, which is their minority ethnic umbrella group for 200 community organizations, principally about vaccination. They all know the data, partly because we're very public with it. We've got dashboards everywhere, and we do daily updates on it, and the news cover it every night. I've never seen so many run charts on the BBC News. They do it every single day. And then they have analysts who tell people what those data mean. I think it's been really good. The challenge to Devi's point, and Devi is correct, that you've got 4 types of harm. Now, we have a very catchily titled 4 harms group. And that 4 harms group is the final point of advice to the Cabinet. And that 4 harms group has the public health advisors, Gregor, me, Amanda Croft, the chief nurse, the head of Public Health Scotland, an economic advisor, the chief economist, a social policy advisor, Carol Tannehill, who's the chief social policy researcher for the government and a public health professional, and the chief executive of the health service for harm number 2, which is health and social care harms outside COVID. So we try and give data and narrative around harm from COVID, harm that the lockdown causes to the healthcare system, social harms from lockdown and COVID, and economic harm. Now, some of that is easier than others. We know the unemployment rate, but we don't know the loneliness rate. So some of the social harms are a little bit more difficult to quantify, but we can do our best to give that advice into a rounded piece of advice, which is why sometimes Cabinet doesn't go the way of the pure public health advice. Nor should it. It shouldn't go the way of the pure public health advice. It has to take a broad approach to the data, the analysis, and then the decision making. Okay,
and Devi, we've heard a lot of sound bites around data in the last year, particularly guided by the science and data, not dates, which we've heard kind of ad nauseum. Do you think they've been meaningful in any respect in the way that the UK and Scottish governments have handled the crisis?
Yes, I think I have 2 thoughts. One is, you can never say you're following the science because the science depends on which scientist you talk to. And as we've seen over the past year, you will find a scientist to tell you anything you want to tell you at this point. You can find your scientist. And so I think, what science can do in advisory roles, I mean, it's similar to what, Jason was saying, is you can lay out, the pros and the cons of different approaches. And what does it mean for R? And what does it mean for transmission and health service capacity? And what does it mean across different harms? And you lay out options and you try to assess them and provide evidence behind them. But in the end, the decision is a political decision. So you can't really follow the science. I didn't really understand that, especially when they were following the science last March and there was no publication of what the science was. It's almost becomes like I'm following God, that's how it felt at the time. The second thing is I think scientists, we haven't always been very good at communicating 3 different types of knowledge that have evolved. So we knew from the start, there were things that we just didn't know. And I think we should have been clear that you don't know, you say, I really don't know. Then there was stuff so January 5th, when, this outbreak was WHO, so there's a cluster of cases in Wuhan, we really, truly did not know if there was human to human transmission. I don't think anyone could say that they knew it. You probably knew it by about the 7th or 8th when more information came out. The second kind of information, I think, things we think we know. So you talk to immunologists and they say, we think we know the T cells play an important role in protection, or we think we know coronaviruses have short-lived immunity given what we've done in the past. So it's kind of using your expert analysis to kind of think something that's not completely valid, but what you kind of hint at. And the third is things we definitely know, facts. We know COVID exists. It's not a hoax. We know that quite a few people end up in hospital. We know it kills people. There are things we know. And I think, when I'm asked questions, I always think in my head, is something I know and things that we know we can all agree on. Hopefully there's consensus on. And then there's things that we clearly don't know. And that's where you hear a lot of disagreement. And then there's stuff that we think we know. And again, you see some disagreement here. And I think sometimes scientists have to be more clear when communicating which of the 3 we're saying, because you often hear people be very confident in things that we just truly don't know. And as you've seen already, if I don't know something, I'd rather say I don't know than actually say something and then get it really wrong.
Okay, I'm just going to go to a few questions from the chat box now. Nick, first of all, if you could have had access to one data set that wasn't available in the early days of the pandemic, what would it have been and why? What was missing, if anything?
Well, I think if we look back and look at how different countries responded to this, there was a kind of early, worry about the NHS and protecting the NHS and trying to get people with COVID back out into the community quickly to avoid the hospitals becoming overwhelmed. And we were pretty slow, I think, to realize the risk in care homes. And I think that's been pretty widely discussed. We still don't really have good information on, where all the care homes are in Scotland and who's resident in them. I think the vaccine rollout has largely solved that, but right at the beginning, we definitely did not. And I think that was one, in retrospect, one area if we'd had more information that would be useful. But I think we had fabulous data to guide this. And if I look at what happened during the first wave, where there was a very substantial increase in excess death due not to COVID. And that partly might reflect that we weren't testing as widely, but partly I think because we really strongly encourage people to stay away, and acute services like cardiology and others were quite quiet when we're normally very busy. That we learned pretty rapidly from collecting information about other conditions, not just COVID, to get that messaging right for the second wave. And I know that just from yesterday's release, there was no excess death due to non-COVID disease during the winter months at all, suggesting I think we learned a lot from that first wave. But I think, care homes was an area where it would have been great to have, I think, more of an insight into where these positive cases were occurring early on.
Okay, thanks, Nick. Jason, another question. It's great to talk about how good our data are, but why are Scottish and UK deaths per million from COVID among the highest in the world? Why has data not helped us do better?
That's an entirely different question. That's not a data-related question. That's got layers within layers. That's to do with virus. It's to do with response. It's to do with existing demographics and inequalities in our country. It's a whole lecture in itself. I don't think the final story for that will be written for some time, actually. If you look at the Euromomo data on excess deaths across the whole of Europe, I have a hunch, and it's no more than that much of Europe will end up in the same place, probably, in light of what Nick's just described about excess deaths over the last little while. Don't look at daily deaths. The age-adjusted excess death rates will be the final data point for the pandemic. That doesn't help the 10,000 people who have lost loved ones, families and friends of me and others who have suffered at the hands of this horrid, horrid virus. But part of that is our response, and our response should be accountable, and it will be. It is every day. You can be absolutely certain that the public health advisors are held to account by the decision makers every day, but there's also broader being held to account by the Parliament, and then there will be a public inquiry. We've already said there will be a public inquiry over time. I think it goes to something Devi said, and I don't quite know how to articulate this. So saying that science knows something is not the same as saying the government knows something. And different governments choose to know stuff at different paces. So I didn't know who Devi Sridhar was 14 months ago. Now I do. Devi is now on the Scottish Government's advisory group to help us with COVID. Now, let's depersonalise it. We also have a whole host of other experts, economics, social policy, public health, who we now have inside the tent giving us the best advice they can possibly give us during this pandemic. Is that one of the reasons why the response has improved over time? I think it probably is. That we've got a broader range of advice that we then have to filter at some level, because there isn't single truth. There is broad truth. And Devi's view, along with mine, along with the chief economists, are how we form into that knowledge that then the decision makers have to make a choice about. We then have layers of government in the UK, which further complexify that, because the UK government gets to make some of those choices, and the Scottish, Welsh, and Northern Irish governments get to make some of those choices. And those lines are not always clear. The clinicians combine and have aligned throughout the whole thing, but the politicians have not always aligned through the whole thing.
Okay, Devi, just take one more question from the box for now, from Jarmo Eskalainen, who's Executive Director of DDI. Before we push for policies to gather more private data, shouldn't we ask whether we use the data we already had to guide our policies? And his contention is, in the first critical month last spring, that did not appear to be the case. We had the data from Asia, and yet the government failed to act. Any comment on that, please?
Yeah, I mean, if anyone has followed some of my writing, I've been one of the harshest critics, not trying to throw stones, but trying to kind of outline that there was other paths available to this. And the thing I would say is, two things. The first is, one of the things, and I've said it publicly before, that SAGE struggled with is they were very like-minded, the people who were on it. It was a very small network. It wasn't transparent who was on it. So you didn't really have different points of view. you had a lot of kind of groupthink. And if you read the minutes from February, you can see the groupthink, because I think there's one minute that says that it was complete consensus in the group that this was an uncontrollable infection and that we must stop contact tracing and build up hospitals. If you read those minutes, they're quite astonishing, because there was not one dissenting voice who said, actually, should we try to suppress? And I think what the Scottish government did when it set up its own group in early April, and I was very surprised to be invited onto it because I had been so vocally, critical, was they said, well, if you want to criticize, come inside and actually be constructive and actually try to help us get this right, because we want to get it right. And so instead of sitting outside, take some responsibility. And I think actually it really makes you see that it's much easier to comment than it is to actually advise carefully. And I think that's something is a lesson for future advisory groups and for scientists. I would rather walk into a room where most people disagree with me and I have to defend my stance, so I see all the holes in it and I understand all the different problems with the data, than to go into one where everyone nods their head and says yes, because then I think I'm flying blind and I might make a really big mistake. So I think one thing is to have different disciplines, different backgrounds, different expertises, so you don't end up with kind of groupthink in science, which can often happen when you have a bunch of people together in a room who all kind of see the world the same way and come from the same background. And on the data, I think it's a question for Europe as a whole. It's not just, as Jason was saying, Britain. Look at Germany now and France and Spain. And the pandemic has different chapters. So chapter 1, the United States suffered badly under Trump. I'll tell you, in chapter 3 or 4, I think they're going to storm ahead this summer. The vaccinations program is expanding rapidly. President Joe Biden has one of the really strong team on top. They have gotten their act together. They might be one of the countries in the summer also, because they have the manufacturing capacity in-house. They can actually produce all the vaccines they need of Moderna and J&J and others to kind of go full force. They've put in place the economic stimulus packages. They're going to race ahead. And then countries that looked really good at the start have suffered quite badly as time has gone on. So I think to say that you can't really assess this unless you kind of see it out for several chapters, and we're not through the story yet. And I think it is, and I'll just conclude with this, that I think we will look back and look at our flu pandemic planning, because we were following that, which was that this is an uncontrollable infection. This is what people said when it emerged in China. And all of a sudden you saw in February, South Korea controlling it, Taiwan, Vietnam, Thailand, not easily. Some of the measures are pretty harsh. The one I keep raising and nobody likes to hear about is border measures. None of those countries suppressed without pretty robust border restrictions and quarantine procedures. They didn't close themselves off, but they basically tried to stop any coming in of any infection and then tried to clear the one they had. And I think in Europe, you can really see it, that we didn't learn that lesson, because we did the harsh lockdowns. We got the numbers low. And at that point, you need to make a decision. Do you kind of try to seal yourself off and get your domestic recovery? Or do you say, actually, we want to stay integrated, but we're going to keep the brakes on mixing? In a way, every country had to take trade-offs and put in place restrictions. The question was, where did you put your restrictions in place? Did you put them at the border? Did you put them between people on the same street? Did you put them on your, on your businesses? So I think, yeah, that was there. New Zealand's really fascinating as well, their story, because they were following Britain, as they usually do, until February, when they read the China mission report and said, actually, we can control this. We don't have to accept it. We should go the SARS route, not the flu route. And they pivoted within a week to actually going in a whole new way off the basis of that. And I think European countries, because we're interconnected, because we want to stay open, have tried to kind of live alongside this virus, but it's too severe. I think right now it's too severe to live alongside. If B117 had come along and been more transmissible but innocuous, that would have been our Hail Mary, right? We would have said, let the virus go. It's like a common cold. It's mutated. We can live alongside it. Unfortunately, it's mutated to a form that's more transmissible and more severe. And then you have the P1 variant in Brazil, which looks pretty awful as well. And one's coming out of New York. So evolution hasn't worked for us. But I'm sympathetic, I have to say. I know I was one of the harshest critics, but having seen this for a year through it and been closely involved through the Scottish Government Advisory Group, there's no easy answers here with a virus like this. Vaccinations are probably now going to do the heavy lifting and our main way through it. And that's kind of what we describe in the article of actually, how do we manage this situation in the next 6 months using the tools we've developed? Because it's here. The pandemic's not going to end tomorrow. It's how do we actually continue for the next 6 months without having the harms accrue?
Okay, just a few points that have been raised, Nick. There's one comment in the box: vaccine passports sound like a nightmare in data merging at a national and international level. What I'm interested in is, in terms of the data lock, you're bringing together data sets domestically. What's happening in terms of data sharing across borders during the pandemic? Because as Devi's just said, we are all completely interconnected. How are we doing on a kind of Europe-wide and international level in terms of data sharing?
There's been a lot of collaborative research done across the UK. ISARIC 4C, led by Liverpool, Oxford and Edinburgh, has been, I think, one of the most robust sets of data anywhere in the world to inform how this condition affects people, particularly severe illness. You know, whether we're sharing at a political level data, well, I don't know. I would defer to Jason to comment on that. But I think as we open up society, we definitely need to be doing that, certainly on a UK-wide basis. In terms of vaccine passports, it's a very, very, you know, sensitive topic. I actually quite enjoyed listening to Jason on Off the Ball telling us how we should do it at the weekend. It's you know, some tough decisions ahead, I think, on policy. And I think, Jason, you've suggested that perhaps the WHO should really take leadership on this because it is an international decision. Otherwise, it's going to be pretty chaotic.
Okay, Jason, any quick further comments on vaccine passports? Then a further question on, you mentioned Falkirk and Stirling as good examples of how data has been shared in public services. Why is that good sharing not happening across the whole of Scotland, and are we taking steps to address that?
Well, quickly, yes, we are. It is happening in other pockets. It was just the example that came to me. I just happened to be in a room some time ago where it was very clear that that's what they were doing. We have community planning partnerships across the nation where local authority, healthcare leaders, police, justice, education come together. They vary a little, but in the pandemic, they've been absolutely crucial to some of the responses. We also have an emergency level of them called the local resilience partnerships, which is the real emergency level individuals who help us in a pandemic. I wonder, just as a side issue, Devi should maybe put 50 pence on her electricity meter if her heating's not on. She's having to put extra layers of scarf on to get through this full hour here. So vaccine passports, I think, is an intriguing but difficult conversation. The headline it's much more difficult than the headline suggests. So let's think about what we actually mean here. What we're actually suggesting is that your medical history will influence what you are allowed to do in your society. Now, that might be the decision you make as a society, but you should be under no illusion that that's the decision you're making. So those of us in Glasgow will know some of the small concert venues or pubs or restaurants around the West End of Glasgow. So can I only go there if I am vaccinated and can prove my vaccination? So that might be the answer, but it's a very, very difficult decision to make. It, of course, needs a data layer, a reliable data layer that we will, of course, do. And we have talks in place. We have people working on that even now about what that evidence would have to look like. It would have to be more than vaccination. It will have to include testing. It will probably include disease, whether you've had COVID, what your antibody levels are, things like that. I would, on an individual level, this isn't the government's position yet, I would want it to be done globally if we can possibly do it. That's how we do yellow fever. That's kind of how we do hepatitis B. So Nick will be, I don't know Nick's medical history, but I imagine Nick is vaccinated against hepatitis B, and he has to be to do his job. I have to be to do when I had a proper job. I wasn't allowed to be a surgeon without a hepatitis B vaccine or a dentist without a hepatitis B vaccine. So we already have gateways. They're rare. So they are hepatitis B and yellow fever. They're the only two examples in the world, really, where your medical history allows you to do stuff differently from those without your medical history. To do that with COVID globally, I think partly it will run away from us. I think the private sector will start to do it. So oil and gas will do it, probably for workers. Other emergency industries around the world will do it. You can see airlines already doing it. Qantas have done it. You now can't go to Israel without a vaccine. One of my pals is the chief executive of the Nazareth Hospital. He's an Englishman. He can't go back to Israel until he gets his second dose and evidence of 3 weeks post second dose. So some of it will run ahead of us. So we as Scotland should be ready for that digitally, I think. But then we also need to take a policy position of our own, which the new government will have to do, about what we think vaccine passports means for freedom inside Scotland.
And Devi Sridhar, is this again a communication issue? There's a big decision, tough decisions to make, as Jason says, but then communicating that decision to the public and getting public acceptance of that is surely the bigger challenge.
Yeah, and sorry for putting on my scarf. I'm from Miami, so like I feel like I'm living in a freezer for most of the year here. I mean, coming back to the vaccine passports and the public, you know, I think there's been two reactions, and the United States has been pushed, kind of, as Jason said, it's running away with us by people saying, why should I get vaccinated if it doesn't change what I can do and what I can't do? Right. And so they're having to look at actually how do they change the guidance for those who are vaccinated fully, because it creates an incentive then for people to become vaccinated because they can rejoin that kind of group. And we're already seeing it, you know, cruise lines saying you can go on cruises if you have 2 vaccines. Israel has green passes. So if you're vaccinated, you can go to bars and pubs, which would mean that Jason would be very welcome into our clubs here in Scotland as one of the over 40s people here in the country.
No, you were right. You were right the first time.
Okay, sorry. I'm glad I didn't say over 60. And then I think I'm teasing. And then we come back to, you know, what does it mean? And there are a lot of people who don't like it because either they can't get vaccinated or they don't want to get vaccinated. And so what do we do with there? And then you hear the ethical concerns. Personally, my view, and this is not the government view, is that actually it's going to go ahead. It's already happening. I mean, the EU is agreeing it, the African Union is agreeing it. And this is both also driven by the need to open up aviation. We know airlines are suffering badly and they need to get around that 10-day quarantine. And the way to get around it is through having vaccine passports where you can upload your testing history, your antibody history, all that stuff. So in a way, is it the ideal? No. Is it going to happen? Yes. And I guess the question is, how do we get ahead of it? And it's a real question if the World Health Organization will coordinate this, where they still seem very hesitant about that, given the scientific uncertainty, or whether it's just going to happen on a piecemeal approach. We're already seeing Portugal and Cyprus saying they'll take British holidaymakers if they have 2 vaccines. It's happening, right? And we can't stop it. So then it's a question of how do we actually make it? Because probably what's going to end up happening is those under the age of 30 or 40 are going to be stuck for months with no vaccination and not being able to do very much. And in a way, it feels unfair because if you look at the whole problem of COVID, it has been, you know, largely affects elderly people, but the people who have paid the price for this have been the younger generations. And so in a way, it just continues that inequality. And it's what we do as society, right? It's our moral fabric. But I think we can't neglect that actually the unemployment figures are highest in the age group 20 to 29 and what it has meant for university students and for children as a whole. So it raises those because we know if we're going to vaccinate down, it's going to take a long time to reach the younger groups. And those are the groups who probably we need to be reaching out to already and trying to kind of get back, you know, integrated and moving and back to some normality.
Okay, thanks. Just one more question before we kind of move to wrap up. I'll put this to you, Nick. There's a question about incomplete and non-comparable data, saying that the number of cases and deaths from influenza isn't statistically known as we don't test everyone when flu symptoms present, though we are testing for COVID. And the question is, does using this type of non-comparable data to inform and shape political policy around health cause panic for no reason? So what about that incompleteness of data and that selectiveness of data?
I don't agree with that. I think we absolutely test in patients with severe flu and are admitted to hospital everybody. And we've got a very good idea of the impact of flu on critical care admissions and on mortality. It's not so relevant that we don't test widely in the community. It's about the severe illness. So I think we know very well what the incidence of mortality is from flu, and it varies a little year by year. And COVID is completely different on a different scale in terms of its severity and its risk to life. So I don't think the lack of data on other viruses really has undermined our response here at all. I think a lot of people would like it just to be like flu. Unfortunately, it isn't.
We also have surveillance data for flu. So we have what we call sentinel GP practices all over the country, which we've also used for COVID, actually. They were our first port of call for asymptomatic testing. So we sentinelly test everybody who arrives at those GP practices with a respiratory disease of any kind in the winter months. And we have statistical clever people who can then ramp that up into a national prevalence data so we know exactly how much flu there is in the country.
Is that a job description, Jason? Does that go on the form? We're looking for statistically clever people.
Boffins. You call them boffins.
Okay, well, we'll just move to kind of wrap up now. I'd just like to ask each of the panelists in turn. I'll come back to you first, Nick. What would you say is the most important thing that you've learned personally and in the work you do in the last year about how we use data, and what lessons have you learned for the future?
Well, I think the way that we communicate and share information and data is vital. And I think Jason and Devi have done a fabulous job to get the message out. And we've got great support in Scotland for the policies that we've had to put in place to control this. I think the thing I've learned most is what an adaptive, resilient, wonderful organisation the National Health Service is. I kind of always knew it because I've worked in it for 20 years, but just to see the way that they responded to this was remarkable. And I have no doubt that they've learned the lesson of how important health and care data is going to be to inform our response to future challenges, whether that is our aging population, multimorbidity, or as Devi says, the next pandemic, which will come.
Devi, what's been your big learning from the last year? I'll give you about a minute and a half.
Okay, well, on a serious note, I think it's about triangulation of different data sources, that you never rely on one data set or even one scientist. You actually have to rely on comparing different data sources. So even the issue of schools, which is one of the thorniest issues, having worked on it for a year, I will never just look at one data set and say that's what you do in schools. You have to look across observational data, modeling data, virology data, anecdotal data, what are teachers saying to you, and then and for the next pandemic, I was in Dubai last Christmas. I should have just gone to Sydney from there and stayed on the beach for the last year and a half. So maybe for the next pandemic, am I going to get involved as I was this time? I don't know if I will or I won't. It's been a rough year.
Jason?
She will. I think the first thing that came to me when you asked that question, I mean, there's multiple answers, is data literacy rather than data completion. So of course we need good data. We need it to be transparent. But there's something about data literacy at every layer of society. And I think this organization and others, webinars like this, help us with that. From the politicians who now know to ask for statistical process control charts, who understand the nature of data over time, not reacting to a single day's positive cases, the nature of lag data and working out whether that death data actually means, because that actually was 6 weeks ago. That's a positive case from 6 weeks ago. All of that. But then also in society, I did 2 webinars yesterday with high school students about lateral flow testing to try and encourage them to take part in our lateral flow testing. S1 to S3s, 12, 13 and 14-year-olds asking me about sensitivity of testing and how reliable lateral flow testing was. I mean, that's fantastic, that level of data literacy in a new generation who will come through after this. And Devi's right, have suffered greatly because of this pandemic. So I think increasing data literacy in our kids and in our politicians principally has been a huge step, and we should continue to encourage that.
Okay, thanks very much to Jason, to Nick and to Devi for your tremendous insights today. Thanks to everybody for listening in and for all your questions and comments. Thanks to the DDI initiative for arranging this event. There's another event in about a month's time, which is on open finance, ethics and social inclusion. And as panelists from the Bank of England and other places, I hope some of you will tune in again then. Please try to remain optimistic through these challenging times. Remember, we've all got an extra hour of daylight come this weekend. So enjoy that when it comes. Enjoy the rest of your Wednesday. And thanks very much again to everyone for joining us today. Cheers.